Good morning, FNP students. This is Molly Bachtel here today with you remotely to go over some back pain case studies with you. I know you've had the back lecture by Dr. Evans, and I think you'll really enjoy going through these case studies to reinforce what you learned in her presentation. All right, and before we get started, I just want to point out this article that Dr. Evans provided for you in 517, which will probably be a good guide as you work through these case studies, the diagnosis and treatment of acute low back pain. So you might want to have this handy, either electronically or a printed copy, as you work through the case studies. There are going to be embedded questions that are for your benefit, not for a grade, within the case study, but I'm hoping everybody will take the time to complete the case study. All right, and here is case one, a patient named Marion. This is a obese 35-year-old housekeeper. She comes in with low back pain, and she's basically saying, hey, I want a back x-ray. She reports having this pain on and off for several years. However, for the last 2 days, it's worse than it's ever been. It started after she vigorously vacuumed a rug, and the pain is located mostly on the right lower side of her back, radiating down her posterior right thigh to her knee, but is not associated with any numbness, tingling, and it's relieved somewhat by laying flat on her back with her legs slightly elevated, and also taking ibuprofen over the counter, 400 milligrams, seems to help. Now, except for her being moderately obese, and she's having a little difficulty, maneuvering on the examination table due to the pain, her exam is pretty much normal. You do note a positive straight leg raise test, and it seems like it's worse on the right leg, which elicits more pain than performing this maneuver on the left leg. Her strength, sensation, and deep tendon reflexes in all extremities are normal. All right, so thinking about Marion's symptoms and exam, you're going to want to create a differential for her. Go ahead and look over Table 1 in the referenced article and kind of scan down the list and see which items jump out at you as the likely diagnosis. Maybe go ahead and select your top 3 and enter them into the question box. Okay, great. As we look down the differential diagnosis list in Table 1, we don't have any signs that there's any compression fracture. I mean, vacuuming vigorously is not quite a trauma. So we won't count that as a traumatic type of injury. With the lumbar strain sprain, this is something to consider for sure. Spinal stenosis and the spondylolisthesis, both of those say the leg pain is greater than back pain, and we're not getting that history from Marion, so I think that's less likely. As far as any systemic cause of this low back pain, we're not having any reports of generalized symptoms, no fever, no weight loss history, anything like that. And then in the referred category, we don't have any history of any abdominal pain or rashes or anything else to suggest a cause such as this. So all that being said, go ahead and select your diagnosis. Okay, and many of you probably reached the conclusion that this is a case of acute recurrent low back pain, knowing that many times with reoccurrence, the pain is actually more severe. In this case, the patient appears to have a sciatic pain going down the right leg, and there's no red flag signs from the red flag table in the article Table 2. All right, so let's say you made the diagnosis of acute low back pain. Now we've got to decide how we're going to treat this. I think our first consideration is that this patient came in asking for an x-ray. Do you think she needs an x-ray? Yes, and most of you probably said, imaging isn't really warranted for most patients with acute low back pain because, this patient doesn't have any serious signs or symptoms indicating a more serious underlying cause. No red flag symptoms, as we said. So the goals of our treatment are really to, relieve the pain, improve her function, and reduce her time away from work, and help her cope with this until it gets better. So now, creating your plan for this acute low back pain, cover the following items. What kind of prognosis does this patient have? What kind of recommendations do you have for this patient regarding activity? Are there any medications you will prescribe for this patient? Okay, thank you for your responses. I'm sure many of you included reassuring the patient that the prognosis for low back pain is often very good, with most cases really resolving without any interventions or very little. As far as activity recommendations, you may want to advise the patient to stay as active as possible, avoid lying in bed for long periods. There was a time back when I was a teenager, I had a horrible case of sciatica and I was put on bed rest for a week. And I think newer studies show that just makes you more weak and more prone to back pain. So the newer recommendation is to stay active, but avoid doing what hurts. If it hurts, don't do it, kind of thing. Return to your normal activities as soon as possible. You definitely want to advise them to avoid any twisting or bending. You might want to actually demonstrate good back maneuvers, positioning, sleeping positions, how you properly lift objects, that you don't bend over all the way, you don't hold things with your arms extended, that you want to keep any heavy loads close to your body, that kind of thing. As far as medications go, there's no doubt that the non-steroidal anti-inflammatory drugs, NSAIDs, are first-line therapy. There's some evidence it helps short-term relief compared to placebo. You can try Tylenol as well, or instead of an NSAID rather, but there's really not a good study showing that NSAIDs are more effective than Tylenol. So you wouldn't do both, one or the other. I usually start with the NSAID myself, just the idea that there's inflammation. With some of these strains, it makes sense that this would be more helpful, but the evidence really isn't there. Now, as far as muscle relaxers go, there is some moderate quality evidence that non-benzodiazepine muscle relaxants such as Flexeril or Xanaflex or Scalexin are beneficial. Most of the pain reduction from these medications is within the first week or two of use, but then they could be continued for up to 4 weeks. There's not really good evidence that Valium is that beneficial. Now, there is some evidence that using an NSAID with a non-benzo muscle relaxer is advantageous. And what about opioids? Did any of you think opioids might be a good solution for this patient's discomfort? There's not a lot of evidence about benefit with prescribing opioids for low back pain, and no difference in the time that we return to work. If you do choose to prescribe an opioid for low back pain, you'd want a very short course, maybe just a day or two worth of medication to get them through the worst of their pain. Okay, so your patient Marion comes back to see you in a month, and let's say she's saying that her pain isn't much better. What will your next steps be? Okay, great. Yes, you'd want to consider changing to a different NSAID. And then it might be time to consider some referrals for physical therapy if you didn't do this at your initial visit. You would definitely want to reevaluate for any new worrisome red flag symptoms and consider referring to a spine specialist if the pain is severe or the function is limited. As you may know, with physical therapy, a big part of the sessions is instructing patients on exercises to do at home. And so when they follow up with you, you have to really clarify, are they just going to physical therapy sessions or are they actually doing the exercises at home as well? So if they're not improving because they're only exercising with the physical therapist and not doing the prescribed sessions at home, then that may be part of the issue with facilitating the recovery to their normal functioning. So other pearls of wisdom is just, if people are seeing chiropractors, there's not a lot of evidence that this is helpful, but nor is it mentioned that it's harmful. So if this is something they're doing as an adjunct to your therapy, I would say that's fine, but there's certainly not evidence to refer them on for that. And then, this is really the case of Marion. This is the back pain you're going to see most often. So we'll proceed to some of the other cases, which are more, worrisome, and that there's some red flags. So we will proceed to the next case. All right, and here we are with case 2, a young woman named Aboka. She's a 32-year-old woman from Nigeria, and she comes in complaining of persistent low lumbar back pain for about 3 months now. She has also had a low-grade fever and night sweats. She denies any extremity weakness or risk factors for HIV. And she has a normal exam except for point tenderness of the spinous processes of L4 and L5. Okay, and as we think about the differential diagnosis for Aboka, definitely keep in mind that she is from Nigeria and she's 32 years old. There's several things to think about on the differential list, table 1, because of this reported low-grade fever, and she also has tenderness on exam to the spinous processes of L4 and L5. There is one item that should be in your differential that is not listed in table 1, and so just think about what that one might be, what's missing from the list that might not be a common problem in U.S. born patients. Okay, so you've considered the differentials. As I look down table 1, I see several items that catch my eye, considering that she has the fever and tenderness at the spinous process. I would definitely consider connective tissue disease. And the tenderness of the spinal process would also make you think of a malignancy. However, she doesn't complain of any weight loss. That is not mentioned, so we assume she hasn't lost any weight. And then what about the vertebral discitis or osteomyelitis? That also has spinous process tenderness, but often with no fever. Okay, and there's one more thing to consider. I hope you thought about it, and that is this patient could possibly have a case of extrapulmonary TB. We know that spinal tuberculosis is a form of tuberculosis, and spine involvement is one of the most common locations for extrapulmonary TB. Okay, so what do you think? Is this musculoskeletal cause? And what's your rationale? Okay, and finally, what is your most likely diagnosis? Okay, I realize you don't have all the information of tests we would want to do on Eboka. Certainly, testing for TB is in order, and I would still do an HIV test. You know, with this, is likely to be musculoskeletal and cause because we have the systemic symptoms of the fever and the night sweats. With her being an immigrant to the United States from an area where tuberculosis is common, I'd be very suspicious for a case of what's called Pott's disease or Pott's spine, which is the spinal tuberculosis. So, you know, we'll go from there, probably referring a specialist to get this worked up further after doing some initial testing. It's interesting that there has been a family predisposition for spinal tuberculosis, genetic susceptibility rather, has been demonstrated more recently. Other risk factors include poverty, overcrowding, illiteracy, malnutrition, alcoholism, drug abuse, diabetes mellitus, immunosuppressive treatment, and very commonly HIV infection. It's pretty well known that HIV infection and tuberculosis can travel together. The progression of spinal tuberculosis is actually slow and insidious, and certainly this patient's history of having continuous symptoms for about 3 months is worrisome for this illness. About 20 to 30% of patients with this condition will have constitutional symptoms. The constitutional symptoms are present in about 20 to 30% of cases of spinal tuberculosis. Typically they'll have malaise, loss of weight, an appetite, night sweats, which our patient has, and reporting an evening rise in temperature that our patient Ebola does report. Also, they can have generalized body aches. And back pain would be the most frequent symptom with spinal tuberculosis. The pain can be either constant, mild dull ache to severe and disabling. The thoracic spine is the most commonly involved area of the spine, so that would not be suggested in Ebola's case, since she had lumbar spine tenderness on exam. We should definitely consider some of the other items on our differential list, including malignancy and connective tissue disease, but I think we do have to rule out the spinal tuberculosis. As far as imaging goes, plain conventional radiographs can be a good place to start, whereas CT and then MRI is going to be the most detailed in showing the extent of the damage and any spinal cord involvement. But you'll start with the plain film and to help pull this out. All right, now we're proceeding to our next case. This is case 3, Alice. Alice is a 70-year-old woman who comes in with a 4-week history of low back pain, generalized weakness, and also reports a 15-pound weight loss over the last 2 months. Her medical history is unremarkable, and her exam is normal, except she is generally weak. You do get some initial laboratory tests, and she does have an elevated sedimentation rate, mild anemia, a creatinine level of 1.8, and a calcium level of 11.2. Okay, so hearing this bit of history on Alice, what red flags do you see? Look over the Table 1 list if you need to, and go ahead and identify some red flags in the history and in her labs. Okay, great. After looking at Table 1, I think definitely jumps out that there's a couple conditions that are systemic that are associated with weight loss. So I think that's the first thing you should be a red flag in her history. So both connective tissue disease and malignancy are associated with weight loss. So I think those two would be at the top of your differential. Now, not every bit of information listed is on the table. We're not given the history information if her pain is actually worse, that worsens with rest or not relieved by rest, as is the case with musculoskeletal cause. And then, of course, we've got this high calcium level. Also, we have the anemia. And then what do you think about her creatinine? Is that a normal finding? We do see on Table 1 that an elevated sedimentation rate or C-reactive protein level is associated with the vertebral discitis or osteomyelitis. It's another bit to consider. And so here is the question again. Is this musculoskeletal an etiology? Why or why not? Okay, I'm sure most of you got this right in the fact that we have these systemic symptoms. It really points away from a musculoskeletal cause, and we need to think of some of these red flag issues. A musculoskeletal cause would not cause weight loss, nor abnormal renal function, nor anemia, nor the elevated calcium. So what is the most likely diagnosis? Go ahead and log your response. Okay, great. Thanks for giving us your response. Yes, I agree that malignancy is the most worrisome and the most likely in the differential. She does have the weight loss and fatigue, weakness in her history. And then we have several laboratory findings that are very worrisome for a case of multiple myeloma. We have the high blood calcium level, poor kidney function, the low red blood cell counts, anemia, mild anemia. So we think we have a case of multiple myeloma, and often the back, the hip, or the skull is where the pain is often found in these cases. It could be in any bones, but those are the most frequent sites. This patient is going to require a further workup, and there's many options to further confirm this diagnosis. They have some quantitative immunoglobulin tests in addition to the basic lab tests we've already done. There's an electrophoresis test that looks for immunoglobulins produced by the myeloma cells. There's a free light chains test. This is more helpful in rare cases of myeloma. There's a beta-2 microglobulin. This test, it also is a protein produced by malignant cells. It's a useful indicator of the patient's prognosis. The higher the level means the disease is more advanced and may be a worse prognosis. We don't mention it, but albumin levels can be low and a sign of more advanced myeloma. And then probably the most definitive test is the bone marrow biopsy. This can be done either at a doctor's office or in the hospital. So as a primary care provider, you'll be referring to a specialist to have this test performed. Okay, and last but not least is case 4. This is Samuel. He is a 52-year-old man who comes to your office complaining of decreased sensation in his buttocks and ability to achieve an erection. On examination, he has a decreased anal sphincter tone and decreased ankle reflexes bilaterally. Okay, and this is a case you may be able to figure out just based on this quick blurb. So go ahead and give me some differentials here that you're considering. Okay, great. Hopefully you looked at the table 2 red flags for serious etiologies of low back pain. And what really catches your attention is this, this loss of sensation, the sensory deficit. And on exam, he has a loss of anal sphincter tone. And there's just one condition really that this points to. And it is the Cauda-Equina syndrome. Cauda-Equina syndrome occurs when the nerve roots of the cauda-equina are compressed and disrupt the motor and sensory function to the lower extremities and the bladder. So often you will have the history that's mentioned in Table 2 of having bladder or bowel incontinence, urinary retention. And so I think maybe this inability to have an erection is kind of pointing in the same direction as those symptoms would. Now, this condition is not related to gender or race. We see this primarily in adults, but there can be some trauma-related Cauda-Equina syndromes that can affect people of all ages. There's a very small percentage of patients that have undergone surgery for lumbar herniated disc that can develop the syndrome. But the most common cause results from a massive herniated disc in the lumbar region. And this little disc material degenerates naturally as you age, and the ligaments that hold it in place begin to weaken. And that begins the degenerative process. And then you can just have a small minor twisting movement that can cause the disc to rupture. Spinal lesions and tumors can also cause this syndrome, as well as spinal infections, lumbar spinal stenosis, violent injuries like gunshot wounds or auto accidents. It can be a birth anomaly as well. Spinal hemorrhages or postoperative lumbar spinal surgery complications, or even spinal anesthesia. Okay, and just let me know, do you know of the tests that are helpful in making this diagnosis? Yes, an MRI that produces the three-dimensional images of the body structures can be used to have a good look at the spinal cord and nerve roots and surrounding areas. The other test that can be done is a myelogram, and this is an x-ray of the spinal canal following injection of a contrast material. And this can show the displacement on the spinal cord or the spinal nerves due to the herniated disc, bone spurs, or tumors, etc. This is a diagnosis that would require prompt emergent treatment. So if you have a patient presenting with these symptoms, they would need to go directly to the ER. Prompt surgery is the best treatment. In fact, if patients receive surgery within 48 hours, they have a significant increased likelihood of improving their sensory and motor deficits, as well as return of urinary and rectal function. but even people who have surgery after the 48-hour window can have considerable improvement in their symptoms after surgery. There can be gradual improvements in deficits for years following the surgery, and there are drug therapies that help with the residual symptoms, coupled with intermittent self-catheterizations that help lead to a slow but steady recovery of the bowel and bowel function. Thank you so much for participating in these case studies. I hope it was very helpful. You know, like I said, the first case is what you're going to see a lot of, but be on the lookout for these red flag symptoms that suggest other causes beyond the musculoskeletal. And I hope you have a really great weekend.